which is, as many of you know, a collaboration between cardiology and the Department of Global Health. It's been a good 16 days since I started, and this is going to be our very first event for this new Global Cardiovascular Health Program. I'm very pleased today to have the privilege to introduce Dr. Anubha Agarwal, who's currently staff cardiologist and instructor of medicine at the Division of Cardiology at Northwestern in Chicago. And I'll just give a few words of introduction before we get into her talk today on implementation science approaches to heart failure care. Dr. Agarwal completed her undergraduate degree at Columbia and then went on to Stanford, so has been here on the West Coast before for medicine. She then did a Fogarty Fellowship with Duke, and many of you may know Dr. Jerry Bloomfield, who was her mentor during that time, looking at cardiovascular effects of indoor air pollution and a cook stove intervention. As a resident and cardiology fellow at Northwestern, she then worked with Dr. Mark Huffman and has focused on improving heart failure care in India. This includes a number of different projects, but one in particular, which is looking at a polypill potentially to treat heart failure with reduced ejection fraction. She's been honored to receive a fellowship at the George Institute for Global Health, which she is currently working on, and a number of other international awards, including the World Heart Federation Salim Yusuf Emerging Leader Award, and she was third place in the fellow category at the Northwestern Cardiovascular Young Investigators Forum, a very prestigious research competition. So we are very pleased to have Dr. Agarwal visiting today. I know we hear this frequently, but I honestly can't think of anyone who's more of a rising star in our emerging field of global cardiovascular health than Dr. Agarwal. So you have the stage. Looking forward to it.
Thank you so much, Chris, for the kind introduction, as well as the invitation from you, Rob, Judy, and others to visit today. As Chris mentioned, my name is Anubha Agarwal. I'm a current instructor of medicine at Northwestern University, as well as a visiting research scholar at the George Institute for Global Health. And I'm incredibly excited to share my work with you today on implementation strategies to improve global heart failure care. My team and I have a HFrEF polypill patent pending, and the research that I will be sharing with you today has been funded by a variety of sources, including the NIH Fogarty Fellowship, the Duke Hubert Jurgen Center for Global Health, the Northwestern Institute for Global Health, the George Institute for Global Health, as well as a pending NIH K99 R00 Pathway to Independence Award. Over the next 30 minutes, I will share with you a case, review gaps in implementation of guideline-directed medical therapy for patients with heart failure with reduced ejection fraction. For the non-clinicians on this call, that is a subset of patients who have whose heart function doesn't work as well. And there is a suite of medications that we know improves mortality and morbidity in these patients, which I will be referring to as GDMT from now on. An overview of existing implementation strategies to improve GDMT rates, as well as novel implementation strategies, including a polypill-based strategy. We'll review pathways for training in this fairly nascent field of global cardiovascular health research, and end with future directions of my research program and what I hope to add to and contribute to the wonderful program here at University of Washington. So to begin with a case, as an NIH Fogarty Fellow based in India in 2017, I had the privilege of meeting a patient whose story I will share with you today. Mr. K is a farmer in Kerala's famous coconut plantations. And in 2017, he was hospitalized at Lakshmi Hospital in Palakkad, Kerala, with acute heart failure. He was diagnosed with de novo heart failure with reduced ejection fraction, underwent an appropriate diagnostic evaluation, including a cardiac catheterization, and underwent IV diuresis for decongestion. Prior to hospital discharge, he was started on lisinopril 5 milligrams as part of guideline-directed medical therapy. Unfortunately, Mr. K missed his 1-month follow-up visit due to the famous monsoons in Kerala, but he was able to come to a 6-month follow-up visit. And amidst a busy cardiology outpatient clinic where one cardiologist can see up to 100 patients in one day, his lisinopril was continued, but no other components of guideline-directed medical therapy were added at that time. Mr. K kind of missed refilling his medications amidst the harvest season and was re-hospitalized with acute heart failure in 2018, 2019, 2020, and 2021. 4 years after his initial diagnosis of HFrEF, he remained only on lisinopril 5 milligrams and did not benefit from the suite of guideline-directed medical therapy that we know improves mortality and morbidity of these patients' lives. So the question that I pose to you today is, we know how to save lives of HFrEF patients with optimal implementation of GDMT, yet somehow we do not consistently do it. Why? This gap between clinical guidelines and clinical practice is the gap that I aim to focus my career on. As a cardiovascular implementation scientist focused on global heart failure, I spend my time thinking about getting what works, i.e. guideline-directed medical therapy, to the people who need it with greater speed, fidelity, efficiency, quality, and coverage to improve population health, especially as the burden of heart failure continues to grow both globally and locally here in the United States. The CHAMP Heart Failure Registry has demonstrated gaps in guideline-directed medical therapy rates in the United States. The light purple represents the proportion of participants who do not have a contraindication to GDMT and are not treated. This gap is replicated in other observational registries globally, including the Asian Heart Failure Registry, which includes up to 11 different countries in both South Asia, Southeast Asia, and East Asia. And again, here you can see the clear gap in GDMT rates, and particularly in mineralocorticoid receptor antagonists, which is one important class of medications in GDMT for patients with HFrEF. Gaps in GDMT rates in India are similar to the gaps that we see in the United States and Asia. The first heart failure registry in India, the Trivandrum Heart Failure Registry, which was started in 2012, revealed that 1 in 4 patients with HFrEF were discharged on GDMT. I started collaborating with Dr. Hari Krishnan, the PI of the Trivandrum Heart Failure Registry in 2017. And together we demonstrated that a lack of GDMT is associated with a higher mortality at 5 years. The desire to close the gap between these two curves that you see between the patients who were not discharged on GDMT and the patients who were discharged on GDMT has been the foundation of the work that I've done and that I'm excited to share with you today. So the first question that I asked was, can hospital-based quality improvement interventions improve rates of GDMT? Funded by the NIH Fogarty Fellowship, I lived in India from 2017 to 2018. First, I led a systematic review that included 14 randomized controlled trials of existing in-hospital quality improvement initiatives for patients who are hospitalized with heart failure. And learned that there was really no consistent effect from these quality improvement interventions on GDMT rates at hospital discharge. But importantly, there were no trials from low and middle income countries. I then did qualitative research, including 21 semi-structured in-depth interviews to facilitate and better understand the key themes on both facilitators and barriers of heart failure care in Kerala. One of the important themes that emerged from this work was that there's been a historical focus on acute coronary syndrome and a lack of attention to heart failure in the region. Armed with this data, my team and I led the first quality improvement intervention for patients hospitalized with heart failure in India, also known as HF Quick, Heart Failure Quality Improvement in Kerala. The quality improvement toolkit that we studied included patient education materials in Malayalam, both for patients and family members, audit and feedback mechanisms where we captured data on heart failure quality metrics from patients and hospitals and fed it back to the investigators at each hospital site, as well as admission and discharge checklists. We learned that among 1,400 patients hospitalized with heart failure, this locally contextualized quality improvement intervention increased GDMT at discharge from 28% in the control period to 41% in the intervention period. Despite this improvement, more than half of patients remained suboptimally treated. And as you can see from the graph on the right, there was a concomitant decline over time, suggesting that additional implementation strategies are needed to improve care for this patient population. We propose to simplify the care of HFrEF patients by shifting the treatment paradigm from sequential initiation and titration of guideline-directed medical therapy to a pragmatic implementation strategy of a HFrEF polypill, where we combine this suite of life-saving medications into one pill, really borrowing from the effects that fixed-dose combination therapy has had on transforming HIV care, as well as hypertension, to a new therapeutic area of heart failure, and specifically heart failure with reduced ejection fraction. This strategy directly addresses the broader recommendation in the heart failure community for simultaneous initiation of medical therapy at hospital discharge. Importantly, HFrEF polypills are an important implementation strategy, but are not going to be the cure-all. They do exist within other existing implementation strategies to increase rates of GDMT, including providing interactive assistance, using financial strategies, developing stakeholder interrelationships, supporting physicians, engaging patients, using evaluative and iterative strategies, training and educating stakeholders, adapting and tailoring intervention to the context, as well as changing the infrastructure around us. So the HFrEF polypill is a great idea, but what is the potential effect of HFrEF polypills on increasing GDMT rates in India? As I'll take you back to the first heart failure registry in India, the Trivandrum Heart Failure Registry, which demonstrated that 1 in 4 patients with HFrEF are discharged on GDMT. We were able to increase the rate to 2 in 5 with the use of a locally contextualized quality improvement toolkit in HF Quick. And secondary analysis of our team's HF Quick data demonstrates that up to 4 in 5 patients with HFrEF are actually eligible for a HFrEF polypill based on clinical and laboratory parameters. As you can see, a polypill-based strategy has the potential to transform care for this population in Kerala. To better understand the context, as well as acceptability, fidelity, and other implementation science outcomes of a polypill-based strategy, we conducted a stakeholder survey amongst cardiologists who are members of the Cardiological Society of India, kind of the most important professional chapter for cardiologists in India. 93% of the participants in this stakeholder survey were cardiologists representing 21 different states in India. The majority of the participants were male, and more than 75% of the participants worked in a private healthcare setting. We asked a variety of questions, including how much of a problem is taking multiple pills daily for your patients with HFrEF. And as you can see, the majority of participants identified that as a large and important problem. We adapted key implementation science measures, including acceptability of intervention measure, intervention appropriateness measure, and feasibility of intervention measure developed by Brian Weiner and others, and demonstrated that there was a high degree of acceptability, appropriateness, and feasibility of a HFrEF polypill-based strategy across all implementation outcome measures. Armed with this data, I conducted in-depth interviews via Zoom with cardiologists, internists, nurses, patients, and pharmacists this past year to better understand the context of implementing a heart failure polypill. Some key themes that emerged included that some fixed dose combinations already exist in India, suggesting that a polypill-based strategy may have high rates of acceptability. Importantly, cardiologists identified that multiple HFrEF polypill doses will be necessary for titration, and that there was an important perception that HFrEF polypills offer relative advantage to existing strategies to increase medication adherence. Using this data, we developed an implementation research logic model. The determinants here on the left are kind of embedded within the Consolidated Framework for Implementation Research, or CFIR. And there are both positive and negative determinants that lead to the implementation strategies that we propose, including HFrEF polypills armed with initiation, titration, and maintenance protocols, as well as laboratory monitoring for safety, that we believe will lead to increased patient adherence to a single pill, increased healthcare provider initiation, titration, and maintenance, and a potentially cost-effective strategy that will lead to both important clinical outcomes as well as implementation outcomes. First, my team and I are conducting a pilot randomized trial at Lakshmi Hospital in Palakkad, Kerala, where we are randomizing 40 participants, half to a polypill-based strategy and half to usual care. The intervention is a HFrEF polypill where we combine 4 different medications into one capsule. I have shared with you kind of examples of the specific medications within each class, which we propose to include a beta blocker, an angiotensin receptor blocker, an mineralocorticoid receptor antagonist, as well as an SGLT2 inhibitor. We will manufacture 3 different doses, a half dose to prioritize initiation, as well as full dose and double dose to give providers the opportunity to titrate HFrEF polypills to higher doses to really see the mortality and morbidity effect that we see over time. This initial pilot phase will be done, or the intervention will be manufactured using an over-encapsulation method where 4 different tablets are inserted into one larger capsule. Future studies, as we begin to develop this concept further, will benefit from partnerships with manufacturing companies where the active pharmaceutical ingredients can be combined into one pill. The primary outcome that we will evaluate in this pilot study is an implementation outcome of recruitment of 40 participants at a rate of 2 participants per week, as well as completion of study-related procedures, including screening, randomization, study drug allocation, follow-up procedures, retention, and outpatient transition. The primary efficacy outcome is proportion of participants with adherence to both overall and individual components of GDMT at 4 weeks, measured by pill count and self-report using structured questionnaires. And most importantly, the safety outcomes that we are evaluating is the proportion of participants with any serious adverse events or adverse events of special interest, and the proportion of withdrawals due to adverse events. The main intent of this pilot study is to, ask the question, can we do this and is this safe? This study leads directly to the next phase, which will be funded by a K99 R00 Independence or Pathway to Independence Award. The K99 phase will take the data that we have learned from the pilot study in generating protocols for a larger multi-center type 1 hybrid randomized clinical trial in India of a polypill-based strategy versus usual care. We will use the K99 phase to not only do career development training, but also conduct a heart failure treatment protocol consensus meeting with cardiologists, internists, pharmacists, nurses, as well as patients in India to contextualize the protocol that we've developed and garner local feedback to continue to evolve the protocol. We'll partner that with focus group discussions as well to continue to refine this protocol. The R00 phase, which will be 3 years, will again evaluate a polypill-based strategy versus usual care in 900 participants recruited from 10 different hospitals in the southern state of India. Our primary outcome will be a composite rate of CVD mortality and heart failure hospitalizations at 12 months. We will evaluate a range of secondary outcomes, including the individual components of the primary outcome, adherence to overall and individual components of GDMT measured by pill count and self-report, change in BNP levels, change in LV ejection fraction, change in physician-reported NYHA class, and overall and domain-specific health-related quality of life. The safety outcomes again will emphasize proportion of participants with any serious adverse events or adverse events of special interest, as well as any withdrawals due to adverse events. Perhaps one of the most important aspects of this trial, of a type 1 hybrid effectiveness trial, will be the mixed methods assessment of the implementation outcomes using RE-AIM. We will evaluate reach by both quantitative and qualitative data collection, effectiveness, adoption, implementation, and maintenance. I view this as perhaps the most critical aspect of this study to be able to really understand what works, why did it work, how do we translate this to other settings, and how do we scale this to achieve our aim, which is really improving population health. Our HFrEF polypill formative research program is expanding beyond India to Asia with partnerships with Dr. Carolyn Lam at the National Heart Centre of Singapore, as well as in Australia with the partnership with the George Institute for Global Health. Partnering with the George Institute for Global Health, we are also conducting a next generation scan of future manufacturing practices for polypill development. Can we use a 3D printer to create next generation polypills? We're also mapping the regulatory environment both in Australia, India, Europe, and the United States through the FDA to understand, if deemed to be safe and effective, how do we get a polypill-based strategy to our patients and providers for wider use. The last research aim that we are evaluating with our partners at the George Institute for Global Health include economic modeling to evaluate the cost for value for a polypill-based strategy in India, Australia, and the United States. Future directions of my HFrEF polypill research program include implementation in other settings, both within and beyond India, including the United States and Seattle. Evaluating additional multi-level implementation strategies. And I'll take you back to the earlier figure that I shared where HFrEF polypills are not going to be the cure-all, but exist within other implementation strategies to improve care for this patient population. Incorporating new medications into future generation polypills as the landscape for HFrEF changes every day with new therapeutics coming onto market. And lastly, extending the polypill-based implementation strategy to other undertreated conditions, including heart failure with preserved ejection fraction, where more recent trials have really changed the therapeutic landscape for this particular patient population. Complementing my HFrEF polypill research program, some other complementary areas of work that I am working on is working with Dr. Greg Roth here, as well as Dr. Carolyn Lamb, on a global heart failure roundtable where we bring together heart failure registry leaders to better understand how we can use observational registries as a platform for future pragmatic clinical trials and implementation science. Another key complementary area of my work is working with Elizabeth Kasani and Anushka Patel at the George Institute in understanding quality of cardiovascular drugs in Indonesia in a landscape where substandard and falsified medicines are a real problem in global health. I will bring you back to the case that we started with, Mr. K, who, as you recall, was hospitalized with acute heart failure in 2017, was only started on one drug of the at least 4 classes of GDMT available to us, and was rehospitalized with HFrEF in 2018, 2019, 2020, and 2021. Can imagine a world where we have a HFrEF polypill-based strategy available to Mr. K so that he is discharged on one polypill, which is titrated up in subsequent outpatient clinic visits. And he only has one pill that he needs to remember to take. And that pill is easily titrated by titration protocols in outpatient clinics. And this is the work that I hope will improve Mr. K and other patients' lives. I'd like to take a segue to review pathways to training in global cardiovascular health research. And this is really for kind of the trainees, both in the Division of Cardiology and the Department of Global Health that are on this call, to share with you my own path. My interest in global health really began as an immigrant to the United States. I was born in India and kind of spent a lot of time traveling between India and the United States as a child, witnessing inequities, both kind of within our country and between countries. As an undergraduate, I had the opportunity to work with Dr. Jeff Sachs at Columbia University and spent a year working in the United Nations Millennium Village Project, both based in Nigeria and Uganda. Working with community health workers at that time taught me that I really wanted to, pursue medicine as a way to do global health. At Stanford, I developed an interest in cardiology and sought mentorship from Dr. Jerry Bloomfield, a cardiologist at Duke, and spent a Doris Duke International Clinical Research Fellowship working with him and others in Kenya, evaluating the effect of household air pollution on cardiac structure and function. This research fellowship led me to Duke University's 4-year internal medicine and global health residency, where I received didactic training in internal medicine, a Master of Science in Global Health, and had the opportunity to do a NIH Fogarty Fellowship as a PGY4. I worked with Dr. Mark Huffman, my primary mentor at Northwestern, as well as Duriraj Prabhakaran, my primary mentor in India, to lead HF Quick, which is the work that I shared with you today. I came to Northwestern to continue my global cardiovascular health training with Dr. Huffman and others. And while at Northwestern, had opportunities to collaborate with the George Institute for Global Health as a visiting postdoctoral research fellow, which was really kind of a key opportunity for me to kind of expand my research horizons and better understand the landscape of global clinical trials in Asia and Asia Pacific in particular. My future directions will include the K99 and the R00 phase, as well as HFrEF polypill commercialization if deemed to be safe and effective. I think the kind of most important years in my path have definitely been the opportunities to spend time and live abroad through the Doris Duke, the Fogarty Fellowship, and our collaborations with the George Institute for Global Health. My long-term career goals as a global cardiovascular physician scientist include: number one, generating new evidence as a global cardiovascular clinical trialist to improve cardiovascular care in low and middle income countries and bring lessons back to the United States. Number two, to use implementation science methods to contextualize, scale, and increase impact of interventions across global settings. Third, develop expertise in regulatory science to lead large-scale trials and translate findings to global health policy to impact both clinical practice and public health. And lastly, and I think perhaps the most important thing we do as academics is mentor trainees and early career scientists to advance the field of global cardiovascular health research, and specifically for global cardiovascular clinical trials. There are too many people to say thank you, but at Northwestern, my primary mentors, Mark Huffman, Lisa Hirschhorn, Don Lloyd-Jones, Clyde Yancey. In India, my mentors include Duriraj Prabhakaran, P.P. Mohanan, Dr. Hari Krishnan, and others. And of course, Anushka Patel, Anthony Rogers, Bruce Neal, and others at the George Institute for Global Health. I'll stop sharing my screen, and again, just wanted to say thank you so much for the invitation to come visit you today.
Well, thank you very much, Dr. Agarwal. An amazing overview of the landscape, and very, very interesting work that you're doing. I'll take the liberty, perhaps, as moderator to start off our question and answer session. And then I have some hands going up. Rob, you'll be first. So I want to start with this concept of what I'll call reciprocal innovation, which is the sense that there are lessons learned in the developing world that may have applicability to treatment and care here in the United States. And you've hinted at this. We obviously have a big problem with GDMT in the United States as well. So at the same time, we've had some recent evidence from the CONNECT-HF trial, for example, which was published over the summer, that a large-scale intervention to try to improve GDMT in the United States context really failed. And so what do you see as some of the unique barriers in the United States context, and potentially ideas that you may be able to bring back from your work in India to improve and inform our strategies here?
Thank you, Chris, for an important question. I am anxious to start pilot data collection for polypill-based strategy in the United States, and have really learned from Tommy Wang's work in evaluating a polypill-based strategy for secondary prevention of cardiovascular disease in the Southern Community cohort as to how our patients in the US could benefit from such a strategy. I'd love to partner with federally qualified health centers to develop a polypill-based strategy for patients in the United States.
All right, well, I look forward to talking with you more about those ideas, and I'll now ask Rob to ask his question.
Thank you, Anubha. That was a great presentation. This is not my area, but maybe you can, it seems like patient adherence. So there's two parts to getting patients on optimal medical therapy. One is, are the physicians prescribing it, but a big issue has been patient adherence to it. And I noticed that one of your sort of key goals in your studies was to improve or measure patient adherence. And I just, maybe you can enlighten me a little bit. I thought that patient surveys of their adherence were unreliable and overestimated patients' estimates of theirs, and that if that standardized pill counts were less reliable and required electronic pill boxes. And I'm just wondering, is it feasible to measure serum levels or something more objective? If this is going to be a key measure or key measure of success of your strategy. So,
thank you, Rob, for a very important question. And I think kind of patient adherence to GDMT is a very important question. And our pilot study really aims to ask whether structured questionnaires and pill count will be sufficient as a measure to measure patient adherence. I've learned a lot from kind of the qualitative work that was embedded in the GUIDED trial to really demonstrate that clinical inertia is also a key barrier to achieving optimal GDMT rates in HFrEF patients in the US. And I'm curious to kind of better understand using implementation science methods as to which of these barriers a polypill-based strategy could overcome.
Thank you, Rob. There's a question in the chat from Judd Walson. Can you talk a bit about how the polypill approach might differ in implementation strategies between the public and the private sector in India, and how generalizable the work you are doing in Kerala may be to the states where there are significant challenges with public health sector delivery, such as UP and Bihar?
Jed, that's an excellent question. And I have a sense that you've probably worked in UP and Bihar. I am from UP, and I remember Prabhakar, my mentor, suggesting that we do this trial India-wide in UP. And my first reaction was, let's just do this in Kerala, where we know that we've got strong implementation partners. And this is really where the last part of my K99R00 phase, I think, is essential, which is using the RE-AIM framework to understand what aspects of this intervention worked in Kerala, if it does, why it works, and how do we generalize this to other settings, both within India and outside of India. I do think that there will be different challenges in states such as UP and Bihar that have very different public health infrastructures compared to Kerala. India is often a place that I think of as different countries melded into kind of one umbrella of a larger country, given the stark differences in health services deliveries between states. But I think this is really where implementation science shines, is to help us understand how to both contextualize and translate findings to other settings.
Yeah, and we have a follow-up to Judd's question from David Watkins, who's worked with us very closely in Uganda, a much lower resource setting, thinking about some of the upstream barriers to heart failure care in the lowest resource areas, including lack of diagnostics, not even having echocardiography, for example. and low awareness of heart failure signs and symptoms among frontline health workers. You want to add anything further to what you said?
Thank you, David, for that important question. And again, this is where a comprehensive global heart failure program, I think, is key. And I look forward to partnering with you, Chris, and others in kind of evaluating some of these other upstream barriers to heart failure care globally.
Yeah, thank you. And David, would you like to add any further thoughts to that?
No, I was thinking one idea is to explore kind of like a multi-component intervention where you sort of link decentralized diagnosis, so nurse-led or frontline health worker-led echocardiography or screening echocardiography at least, with tele sort of diagnosis at a referral facility, and then rapid initiation by non-physicians, non-cardiologists potentially. So you can think about something like that for settings with very poor referral systems and access to care, but good internet access.
Absolutely.
Yeah, and Dr. Wasserheit, I see your hand is raised.
Thanks, Chris. Anubha, that was a great presentation. I really enjoyed it. So thank you for that. It makes me think about one of the things that I think has helped us move forward with implementation science in the HIV related sphere, and I'm an infectious disease person rather than a cardiologist, so forgive me if this question is naive, but one of the things that's been helpful is the setting of these 90-90-90 targets. And I'm curious, as you think about, or cardiology thinks about trying to really tackle the challenges that you've talked about, are there analogous targets that either have been established or you're thinking about promoting with respect to the proportion of individuals who are aware of their status on whether it's a polypill or another guideline-directed medical therapy regimen, and then some objective test-based measure of achieving improvement. Can you educate me about this, please?
Thank you for that important question, Judy. I think there's targets that have been set by the Sustainable Development Goals on NCD care, broadly speaking. I think within the global heart failure space and what I focus on, which is improving rates of guideline-directed medical therapy, the target would be 100%. This is work that Greg Fonarow talks about frequently, is how, all of these patients who are eligible and how do we get them on to GDMT. And this is where I think the marriage of implementation science and global health, and perhaps the centrality of implementation science methods in global health, I think we can learn a lot from as cardiologists and applying that to improving cardiovascular care in low and middle income countries.
Thank you. Dr. Weiner, you're next.
Hey, Anubha. So I'm going to engage you in a geeky implementation science conversation, which you can look forward to more of if you come and join us here. So forgive me, global cardiologists, for indulging in this. So as you pointed out in your talk, and as we talked about earlier this morning, you've described the polypill as an implementation strategy. And then you went ahead and proposed for the R00 to do a hybrid type 1 with the polypill being treated as an intervention. And this is not all that surprising. There are sort of three classes of things out there. There are things that are clearly interventions that are designed to change patient outcomes, patient behaviors, and so forth. There are things that are clearly implementation strategies, and those are generally ones that target providers or on the supply side of things to get more stuff done that we know works. And then there's this stuff in the middle that's gray that could be either an implementation strategy or an intervention, or possibly even both at the same time. And I think what we talked earlier about how some things that we might not consider to be that we in the United States, in a high-income country, high resource context, would consider to be interventions, would be considered, and could very well justifiably be considered implementation strategies in a low resource country context or country. And this article by Japa and Barningson a couple of years back did a really nice job laying that out, and certainly opened my eyes. This one I think is another interesting case, because the poly pill, on the one hand, as I understand it, it's well conceived as an intervention from the perspective of the patient, because it's designed to increase adherence of patient behavior. And so when you frame it from that lens, it makes a lot of sense to say this is an intervention. But it can also be considered, I think, an implementation strategy from the perspectives of the providers and the provider system, to the extent that it increases guideline adherence in their behavior, so that they're providing care that's consistent, or recommending care that's consistent with the guidelines. Just like Japa and Barnegausen, indicated that some things like point of care diagnostics, which sound like interventions to most of us in the US context, from the perspective of a low resource delivery system, is an implementation strategy, and that frees up resources. It either creates new resources or frees up resources that could be used for other sorts of things. So there's an alternative sort of lenses for it. So there's no question here, so it's a typical academic comment, but just to say this was really great to hear you talk about this, because this insight came from your talk, and I really hope that you come here, because it'd be fun to have more kinds of conversations like this.
Well, Brian, you just hit the nail on the head, and that's exactly why I've tried to contextualize the HFrEF polypill more as an implementation strategy, because often it's viewed as an isolated intervention when we think about kind of drug therapeutic trials. But exactly as you said, I think a polypill-based strategy has an opportunity to hit multiple barriers that we see at the patient, provider, and health system level, which packaging it and thinking about it this way. And I've learned a lot from the systematic review that you and Ariana Means led on kind of using and applying CFR constructs to LMIC settings. And I'm using that in my work in kind of the K99 qualitative work and how to kind of use CFR to develop this as an implementation strategy further. And I look forward to learning from you more.
Well, thank you. Very interesting conversation to be continued. Jake, I think you're next. I still unmute. Yeah.
Yeah, gotcha. Making you change gears a little bit, Anubha. We've got several fellows on the call right now, and several of them are interested in global health. And one, I think you're an amazing role model of somebody who decided early on in her training that she wanted to do global health, and then managed to stick with it, which is not honestly all that common. And it appears that you had to use a lot of creativity and a lot of ingenuity to find funding and time for all of this. So I guess my question would be, in general, how did you do that? But more targeted towards our fellows, what are kind of the core components that you took from all of this that were important for you as a trainee to get you launched as you are to an amazing career as faculty?
Thanks so much, Jake, for that question. I think the kind of most important years in my training were the years that I spent abroad and building those relationships with partners. So my Doris Duke Fellowship in Kenya, as well as my NIH Fogarty Fellowship as a resident in India. The primary data that I collected during my Fogarty Fellowship was the basis for my K99R00 application, which helped me kind of launch that application early as a fellow to transition to early stage faculty. And so I think kind of time on the ground and developing those relationships is key. I recognize that global health is changing and will change in the pandemic and post-pandemic periods, and it will look different. But I think time in the field is irreplaceable, and I couldn't recommend the Fogarty Fellowship as a mechanism higher.
All right, I think Greg is next.
Hi, Anubha. That was really, really interesting. Can you guys hear me okay? Great. So I wanted to ask you a question that sort of builds on something I learned from Julio Frank. You know, he wrote about how they implemented programs over many decades in Mexico as the health system improved there. And he has this idea where you've got vertical delivery programs, how antiretrovirals have been delivered is a great example. And then you've got horizontal programs, and that's really a broader conversation about universal health coverage. And then he invents this idea of sort of the diagonal approach, that you actually use both. It's not a war between these two, but they sort of drive each other forward, and there's a role for both. And so I wanted to actually ask you, as you sort of describe a really detailed program around investigating, this kind of vertical effort to focus on heart failure and HFrEF in particular, it's very hard to not notice that your polypill, your encapsulated product, even though GDMT is not, we don't think of it as designed to lower blood pressure necessarily, it's a bunch of antihypertensives. And I'm curious what you think, about the, potential future steps for your research program that might sort of take this diagonal view and expand to, hypertension first, but, cardiovascular disease more broadly. How do you take these approaches that you're developing, this toolbox of different kinds of trials and studies, and broaden it to look at cardiovascular disease beyond not just HFrEF and HFpEF and heart failure, but, the giant gorilla in the corner, hypertension, and then vascular and thrombotic disease in general?
Thank you, Greg, for such a great question. And it's nice to kind of see you and visit Seattle. I think heart failure is actually behind the times when we think about polypill-based strategies, since there have been outcomes trials in evaluating polypills and primary and secondary prevention of cardiovascular disease that have recently come out and have demonstrated an effect. And the challenge remains actual implementation and scalability in cardiovascular disease, as well as hypertension. A close colleague of mine at the George Institute, Abdul Salam, based in India, is doing incredible work in the region and evaluating fixed dose combination therapies for hypertension. And so to answer your question, in developing protocols, initiation, titration, laboratory monitorings for a HFrEF polypill, I think we have an opportunity with partnerships here at University of Washington, with the George Institute for Global Health, CCDC, PHFI in India, as well as National Heart Center of Singapore, of sharing protocols amidst investigators to really duplicate and replicate and scale the efforts that we're doing in HFrEF and apply it to other disease conditions and cardiovascular care to potentially create a greater impact in CVD.
I wonder if there are any last questions here. If not, we may be able to wrap up a few minutes early. I just want to say thank you once again, Dr. Agarwal, for an amazing talk, and look forward to the continued conversations.